My name is Tiana Ali and I'm working as a research assistant for the Communicate Study project. We are running sessions monthly for our Cultural Safety Champions group, and this group is a mix of doctors, nurses, and other healthcare professionals who are interested in improving cultural safety. Today we have also extended this invite to staff at Menzies, so thank you all so much for coming, and I hope you're all able to take something away from today's presentation. So today we have Associate Professor Dr Dianne Wepa presenting on the topic of cultural safety. Dr. Wepa is an Indigenous Māori woman from New Zealand. She is the head of discipline of social work at CDU and an accredited mental health social worker with Australian Association of Social Work, and holds several adjunct positions with the University of South Australia, University of Bradford, and the UK and Auckland University of Technology. Dianne serves on the editorial board for the International Journal of Education, Culture and Society, and is currently supervising 10 higher degree students in Australia, UK and New Zealand. And on top of all of this, Dianne is also set to publish her 3rd edition of Cultural Safety in New Zealand in early 2024. We feel incredibly lucky and grateful to have you here with us today.
Thank you. I'll just go that way. Yeah. Okay. Thank you, Tiana, for your warm welcome, and also to Madison as well for your hospitality, and to all of you that are here today and online. Okay, let's make a start. Okay, so I thought I would just share with you where I'm going to, and we need to click them through. Sorry, the slide's got something wrong with it there. So I'll go through who I am and equity from a Māori lens, and cultural safety, or kaua whakaruruhau, which is the Māori equivalent term. We-dentity, which might be a familiar term for all of you, or you might think I haven't heard of that, so I think that's of interest to share. First Peoples and Western worldviews, the language use of we and I, Māori worldviews, cultural literacy, which I think is the way forward in terms of health literacy, takeaway messages, closing words and references. So so who am I? I originate from New Zealand. My iwi is Ngāti Kahungunu, which is located on the east coast of the North Island. And you'll see an image there of my marae, or traditional meeting house, called Matahiwi, and it's based in a beautiful seaside region of Hawke's Bay, of Hastings, and it's green. You may have, if you've gone to New Zealand or have familiarity with it, most of the meeting houses are red, and the carver that put together my meeting house decided on green, and the reason is all about growth and new beginnings, and so that's the reason the colour was chosen there. So I'll just start with a definition I'm sure you're all familiar with, and I'll put a Māori lens on that. So the definition I have here of equity is defined by the World Health Organization as the principle of fairness and justice in the distribution of resources and opportunities for health. And in New Zealand, our founding document was the Te Tiriti, or Waitangi, the Māori version, and also the Treaty of Waitangi, the English version. And I thought I'd share that with you all today to give a preface to my worldview and how I see things in terms of equity, and also in terms of Indigenous well-being as well. And in New Zealand, there's been controversy over the translations of the two versions of what we call the treaty, or Te Tiriti, which is the Māori translation. And over time, there have been many interpretations over what that's all about. And the focus I'm bringing today to the session is around health. So I won't go through the minutiae of the two, but what I do say to people is that there were two versions that were signed by Māori chiefs in 1840, February the 6th, over 500 actually, and 35 chiefs signed the English version. And both are actually correct, and both were sent to the UK. We only have a problem when we say that means that, when you try and cross them over. So the people that signed the versions that they believed would happen thought that's what would happen. So that's what I usually share with people, is that the issue is actually trying to say the translation is the same. It's not. There's a word in the Māori version called oritetanga, which means to have the same rights and privileges for Māori as settlers. And nowadays in New Zealand, that's been interpreted to mean equity. And that comes from Article 3 in both versions. So the treaty has 4 articles in the Māori version and 3 in the English. It's a very simple treaty. There aren't that many clauses. And the 3rd article is identical in translation between the 2 versions. And they both say that Māori would be given the same rights and privileges as the settlers. And over time, that's been interpreted to mean health. So if we go forward in time, the treaty, the Treaty of Waitangi Act was established in 1975 by the Labour government. And at that time, there was a lot of unrest in the country, high unemployment for Māori. And the Labour government at the time thought, we better do something about that. And so they introduced the Treaty of Waitangi Act, which established the Waitangi Tribunal that would hear claims against the Crown from 1975. And Māori people felt it was a toothless act, because if the grievance was occurred, say in the 1800s, against the Crown where land was taken and those sorts of things, a lot of that evidence was lost. And so 10 years later, there was an amendment to the Act to allow claims against the Crown to be heard from 1840. And since that time, since 1985, there have been claims against the Crown for various things, mostly around land. And so if there's a claim, it's given WAI in the front, which means Waitangi claim, and then a number. And most recently, there was a claim around health, and it was called the Health Kaupapa claim, kaupapa meaning topic. And within that claim was a claim that noted the persistence of health inequities for Māori, and the Crown used to use what we called the 3 Ps in New Zealand: partnership, participation, and protection. And those principles became outdated. And the claim said that there were lots of occasions with legislation and the health providers, which were called district health boards in New Zealand, where and the public health organisations as well, were still not meeting the needs of Māori and improving Māori health. And so the claim was made, and claims can only be heard by the tribunal, and recommendations are then made to the Crown. So a lot of claims actually don't go anywhere. Lots of money spent and they just stop. And so the Y275 was successful in that there was enough evidence to say that Māori health hadn't improved. And so the claim brought about an act called the Pai Ora Act, or Healthy Futures Act 2022, and that established a Māori Health Authority. And there was a whole reconfiguration of the health system in New Zealand that set up this authority. And what happened with the authority, and because it's quite recent, quite new, the focus was on equity and improving Māori health status. And it really hasn't had time to bed in, because you had to have the district health boards all disappear and come under new entities, Health New Zealand plus the Māori Health Authority. And the government that's in at the moment in New Zealand is disestablishing the Māori Health Authority. And so there's another claim under the Waitangi Tribunal to to respond to that. So it's quite political at the moment in terms of the health landscape in New Zealand. So I'll just push pause on that and come to cultural safety or kawa whakaruruhau. So that you may know the history of cultural safety in the 1980s in New Zealand. Māori health was quite grim, and a Māori nursing student, Henirangi Mohi, she was at what we call a hui, H-U-I, meaning like a gathering, and she was quite tearful, and she says, we talk about ethical safety and we talk about physical and legal safety. What about cultural safety? So the term was coined by a nursing student, and Iri Hapati Ramsden, who's known as the architect of cultural safety, was at that hui, and she thought, well, yeah, that's a really good point. And so she went about developing the concept further with the New Zealand Nursing Council, and standards for registration for nurses introduced cultural safety as a standard for students to be deemed as culturally safe when they practice. And what I found when I was doing my master's back in those days, I was teaching cultural safety, and what I found, there wasn't a body of knowledge on the topic. And in my master's, I interviewed all of the cultural safety educators in New Zealand, and I said, well, how do you teach it? Because it's, a lot of storytelling, or what do you use? And if you compare the knowledge to, say, medical, surgical, nursing, and those things, they've got huge textbooks and an established body of knowledge, but cultural safety was mostly based on storytelling. And the educators all agreed with me and said, yeah, we need some resource that at least helps the educators have some point of reference when they're trying to teach this new component in the curriculum. And so I set about publishing an edited book, Cultural Safety in Aotearoa, New Zealand. And that's become a required textbook in nursing and midwifery in New Zealand for a number of years. And it's also gone into allied health, occupational therapy, physiotherapy, and touched in medicine as well. And so I'm just on to my third edition. So I'm really, really pleased with that in terms of not just my journey, but helping keep the kaupapa, or the topic of cultural safety, alive, because it is a dynamic concept. And I've travelled different places around the world. For example, I was a visiting scholar in the Okanagan with UBC, British Columbia University, and they embrace the concept of cultural safety. And I think any nation that's been colonised can appreciate the journey that Māori have been through, and so they have adapted the definitions to suit their regions, and the same in Australia. And I think that's a brilliant thing. So I do say to people that may be kind of purist in some ways, which is okay, with a theoretical concept and trying to make it practice-based. Like, I think Iri Hapati would be happy to hear that the concept has evolved and it's become dynamic in terms of meeting the needs of people, as we go through time, if you like, and each different country has also adapted it. But they always acknowledge the beginnings, which I think is important. Yeah. And so in New Zealand, if you do study at least, say, a Bachelor of Nursing 3-year degree, the progression's the same. So you start with cultural awareness, knowing about your own biases, own values, and understanding you actually have a culture, because with dominant cultures, we might tend to think that's normal, and other people have a culture because they have interesting food, they dress differently, different language. And so that's really about celebrating our taken for grantedness, the way we brush our teeth, the way we celebrate birthdays, deaths, those sorts of things. That's our culture. So a lot of students in New Zealand from the dominant culture need to be supported to understand they have their own culture. It's not something exotic to who they are. So that's cultural awareness. And then the second year is around cultural sensitivity, power dynamics. So sociology is brought in there, looking at the Treaty of Waitangi and all of that historical information. So it can be tough for some students because we don't teach the Treaty of Waitangi history in our schools in New Zealand. There have been attempts, but it's seen as so political, we just don't do it. So what happens is students come as adult learners and they've already formed a worldview, and then they could be confronted with information as an adult, and it's like, what are you trying to do? This left-wing propaganda. And so I think if we learned about our history, especially the Treaty of Waitangi, in a matter-of-fact kind of way, because it is history, it's happened, I think we would progress a lot further in that space. And then the third year is cultural safety as an outcome of that progression. And put simply, cultural safety is, because it's some would say a qualitative definition, it's all embedded in the person receiving the care. We have to be mindful that it's similar to ethical safety. It depends on each and every event, because you can't say you're ethically safe 100% of the time. You've got to wait until there's an encounter, and then that's where it's tested normally. And that's why I like the term taken for grantedness. So if I think people eat with a knife and a fork, and I'm working with someone providing a service where they eat with their hands, and then I have a reaction to that, this is just a simple example, and that person sees that I'm judging them, that might be the way they interpret that, then they might say I'm culturally unsafe. And it's quite confronting, because people say I'm a good person, like, I'm nice to people, things like that. But it's more than that. It's actually a political statement to say, actually, I don't know all the answers, and I actually give power over to the person to comment on the care I'm providing. Okay. So we move on to we-dentity. Has anyone here heard of the concept? Raise their hands. Ish, yeah, cool, okay. I really love it. I think it's a way to describe how people with a collective orientation identify themselves. So it's not identity, it's we-dentity, and it really makes you think. And I've got here that language is considered the window to a culture because it provides insights and understandings that cannot be acquired elsewhere. And so those of you that may know discourse analysis, things around language and culture, this is nothing new. And it can explain why certain aspects are privileged in one culture and not another. So words are powerful, aren't they? And indicates, that's supposed to be an if, a culture is what you can consider high context or low context, with a collective or individually focused orientation. And I think that's so important in terms of providing a service in healthcare. Some people are actually happy not to be asked about their significant others or their cats or dogs or, those sorts of things. And others would say that's important. And from my experience, the language of the person receiving the care is key. If you listen in, you lean into how they talk about themselves, that gives you an indicator of where you probably should orientate your assessment. So we have here, I love this, I am because we are. I didn't invent that, but it's a saying. And from that, in my PhD anyway, I interviewed 40 Māori families about their loved ones' experience going through the healthcare system. And that was challenging, because that's not 40 people, it's 40 families. And I thought, why did I do that? But it was important to hear the story from the collective. And so when I would ask people about their loved one's journey through whatever healthcare service they had, 100% of the time, the word we would be in the answer. We did this, we did that. Not once did I hear I. And I never thought about that until I started analysing the transcripts. I went, oh, okay, there's something in here. And I do it myself. I talk in the almost like othering the we type thing. So it's really, really interesting. So I worked with that some more. And so what I've got here is, so if, for example, people receiving your service, if they use the term we, then they are referring to their healthcare experience in this way. This indicates that their culture is high context and it has a collective orientation, whereas someone that uses I, mostly in their language, can can be, I'm not saying all the time, but can be from a low context and have an individually focused orientation. So speaking from this collective viewpoint, other phrases that came through my study anyway, used phrases such as Māori we, or as whānau, which is family, we do this and we do that. And some of the quotes were, we don't do anything on our own. We are just worrying about who we're caring for. We're having to arrange people to come with the patient. And one statement was, oh, all Māori do that, making sure that you check up on them. You know, those sorts of things were quite important. Okay, and so what we have is, so the premise of I am because we are is a key premise. And I encourage you to look more at the literature around that, because I think it's actually something that we could be missing in our healthcare interactions. So what we have in Māori culture is mostly dominated by verbs, reflecting the way that our existence is defined by energy and spirit that is in constant transformation. In contrast, westernized cultures use languages that are dominated by nouns. As a consequence, Māori, and I would suggest all First Peoples, tend to attend to the relationship between things and focus less on the characteristic of things that are evident in a noun-driven English language. In healthcare, this can be a challenge to the view that a patient is treated as an individual, and the disability sector in particular focuses on someone moving towards independence, yet in reality, we are all interdependent on each other. So the slide here, I adapted it from Sir Professor Mason Jury. You may have heard of him. He's very famous in New Zealand. He created the Whare Tapawha Māori health model. So I've got the references there if you want to look that further. And so I really love the way he describes different worldviews. So he lives in Fieldings, the small town in the North Island, just a little bit west of what we call Palmerston North, which is different to Palmerston. So I do confuse the two sometimes. I say Palmerston North here, but anyway. And he was repairing his water pump. And he told me this story. And he noticed the way the pump was moving around. And he reflected on the movement and developed this following description, which is, I think, a creative way to use science to help people understand different ways of knowing, doing, and being. And so what I've got here is, these are his terms as well, and I've just expanded on them. So what I'm saying for Māori, the centrifugal focus is like a telescope, which has an outwards direction. Understanding comes from larger contexts. For example, wider relationships and similarities convey the essence of meaning. In contrast, the centripetal focus is a microscope, which has an inward direction. Understanding comes from analysis of component parts. And in psychology, for example, inner thoughts and feelings and differences help gain understanding. So what that means for practice is that we-dentity needs to be recognised and acknowledged when engaging with Māori, and indeed I would argue First Peoples, and incorporating the collective identity of First Peoples and their family, I strongly believe is essential for planning and delivering health services. And we tend to default to the dominant biomedical model, which privileges the individual and independence. And I would argue there needs to be a realignment towards collective orientation and ways of functioning which are interdependent, because what we have now is not working for First Peoples. Now, this might look a bit complicated. I don't know if any of you are familiar with Māori language, but there are not many letters in the alphabet. It's only like 13. And I thought I'd just share this with you. I just won't go too much into detail in case it confuses you. Just thought I would show the differences in language. So there's more than one meaning for I and we. So you'll see there on Māori, the left-hand side is mātou, tātou, māua, tāua. And then the translation in the middle, and then in English, kind of like it's the equivalent of the Māori terms. So anyway, you can study the slides later in your own time. Basically, in Māori, the language is very much we and I has many meanings. That's really my point. It's not really seen as an individual focused language. It defaults to the collective in terms of us and them. So it's always dependent on the speaker. So the speaker's in green, I think, yes, and the orientation is the arrows like the speech going out. I'm not very good at these graphics. And so you'll see there the red person is outside the circle. So the relationship in the language is you in relation to others. So these are key Māori worldviews that are known in New Zealand. So Mason Jury, he makes a key point around that Māori tend to find meaning in bigger pictures. So that aligns quite well with the telescope, metaphor there. And we have Denise Wilson. She's a nurse, nursing professor at Auckland University of Technology. She talks about the Te Kakano whānau model. She looked at Māori women and again emphasised how women tend to talk about the collective as well. So there's sort of gender leanings in that as well. And then Penetito, he talks a lot about identity. He was actually one of the first scholars to really do a deep dive into that. And he proposed that Māori identity is a collective process where people acclaim their Māori-ness to one another. So I think that's quite a nice way he put it. And then Davey and Dwyer, they assert that the Māori worldview is decentered, whereby the universe is viewed as dynamic, complex, and continuous with no centre. And so you do find that in conversations with Māori people in New Zealand, is that if you go, say, an example, say a home visit to somebody, the conversation will be circular, and then you eventually come to the point of the visit, and that's how the language flows, as opposed to if you go with a linear way of saying why you're there, and then go through, whatever process you need to gain whatever you need for your information, you'll actually find it takes longer. And so people are learning in New Zealand anyway, in the undergraduate programs to learn other models of communication that still arrive at the same point, but you may find you have to, navigate that in another way. Cultural literacy. This is where the provider of a healthcare service can reflect and respond to their taken for grantedness about health literacy when communicating with the receiver of the service. Health literacy frames the receiver of the service as deficit in some way. For example, they don't read the pamphlets. They don't take their medication properly. And a person in New Zealand, Susan Reid, who I admire, she's done a lot of work in this area, and she promotes the use of teach back, which you might be familiar with, and also reframing the focus of the provider of the health service needing to reorientate how they understand the culture of the person that they're serving. So you can look more on the references if you're interested in cultural literacy, which is I guess I won't say new, but I recommend it to people if you want to add that to your toolkit in terms of effective engagement with people with cultures that are different to your own. Okay. Getting near the end. So the takeaway messages, I guess, is I recommend to people to, in New Zealand anyway, is the focus is on equity rather than ōrite-tanga, which is the same rights and privileges as others. So what that means is, I guess, beware of the term equity, because in New Zealand anyway, Māori tend to compete for cultural space. And what that means is we say, oh, what about this culture, that culture, start talking of having Māoris lumped together with other cultures. So a common narrative is Māori and Pacific Island people. And that narrative actually removes the special place that Māori have in New Zealand. because where else can Māori go if they can't speak their own language in their own land and practice their health practices in their own land, those sorts of things. And so the Treaty of Waitangi, whether we like it or not, in New Zealand, gave Māori certain rights and privileges, and health and language are the two areas that have been tested, if you like, through the Waitangi Tribunal. So the Māori language is a protected language in New Zealand, along an official language and protected, along with English and sign language. And health is considered a treasure, or what we call a taonga from the Treaty of Waitangi, and that needs protecting. So governments over time have tried to, you could say, honour the treaty's intentions by doing that, by putting some sort of clauses and legislation around Māori needing a special protection. And over time, that's been watered down to the general statement of equity, which actually doesn't work for Māori, because then they're put alongside other cultures that have certain disparities. So it's not a matter of Māori giving more resource than others. It's more about having services that focus on the gap, which is similar here in Australia as well. And so I'd like to sort of think about our taken for grantedness, and that's in the research space as well. Maybe the way I conduct myself around with First Peoples, as an example, I take it for granted, there's a certain way that I do things, and maybe we have to look at that. Consider the use of we from now on when you have conversations with people, and lean into that and just take note and think, okay, that's telling me something. Because people generally don't say, this is what I want in my culture, and they don't come with a list, do they? You have to do the work to try and find that out as the provider of that service or healthcare. And I've got here, actively break down barriers to understanding as language evolves. So I say to people, go and enroll in a Māori language class. They tend to be free. Like, go and do something on an individual basis if you really want to learn about certain cultures that you are working with. And key messages can be lost in translation. The nuances do need to be considered. And language is just one element of culture, as we know. There's other key elements as well, though that's been the focus for today's presentation. And I say to people, keep learning more about the language and the worldviews, and continue to listen with aroha, which can be translated to love or compassion as well. So closing words, I close with a proverb here. So it's mā te rongo ka mōhio, mā te mōhio ka marama, mā te marama ka mātou, mā te mātou ka ora. Once you have been shown, you will know. Once you know, you will understand. Once you understand, you will have information. Once you have information, you will be knowledgeable. And those are my references. Thank you. Close to 40 minutes.
Very good. Thank you so much, Dianne, for coming in. I really want to express my gratitude, for your really valuable talk.
I've got my cards there if anyone wants.
Yay, awesome. Before we wrap up, did anybody have any questions that they wanted to ask Dianne? I have a question.
Sure.
Where can we purchase your cultural safety textbooks from?
Okay.
Yeah.
Yeah. It's with Cambridge University Press. Yeah. And I've gone to an Indigenous publisher for the next one. I just found, as you do with some publishers, it's all about the numbers you sell and things like that, which is fine. So Huia Publishers, I don't know if you've heard of them, Huia the bird in New Zealand, beautiful bird. They're going to be the publisher for my next book. Yeah.
Awesome.
And I have tried to put a case for an Australian version, but the publisher at the time, one of the reasons I've moved publishers is that the publisher interpreted cultural safety to only be about Indigenous stories and health, and I said no, that's where it began, and we're adding, it's an and and so unfortunately, that didn't go to plan, but I think there's a place for cultural safety knowledge everywhere. But yeah, so Cambridge still sells it. It's an e-book as well. I'm happy to sign it. Yeah.
Awesome. Hey, did anybody online have any questions that they wanted to ask? I'll take that as a no. I'm just going into the chat. No, thank you. All right, well, if that, oh, yep, sorry. We've got a question in the room.
Thanks so much, that was wonderful. I just wanted to ask, I mean, I think within health and hopefully health research, cultural safety is just part of the way of working now, and you know, there's interest, but do you find, say, in other realms that, you know, they are much behind or actually more in front as well, say education, legal, public service, you know, other aspects of
I'd like to
society?
think health's in front because that's where it began. Yeah. And nursing most definitely, because that's where, you know, all of the action is where it all happened. And a lot of nurse scholars have taken the concept further. Yeah, and some I think still confuse it with cultural competence and cultural sensitivity. And you'll see that progression. You actually need to move beyond the second step, and the concern there is that people actually remain at the sensitivity level because they don't want to offend, and they become relativistic and say, oh well, if they practice those cultures there, that's for them to do. I can't impose on that cultural practice. However, with the sociology sort of influence, it really requires you to make a stand, and in health, you know, that's what, like mandatory reporting, those sorts of things. So I think, well, New Zealand, I would say, is up there, but not always. It does vary. I think it depends on who takes the lead, because it has become like a commodified thing. So you have centres popping up and that kind of thing. But I think as long as we come back to the tenets of the, you know, this true intention, that keeps you safe too. You know, it's about the person receiving that care or service defining if you are meeting their cultural needs. And if you're not, then you respond to that. So we don't have to be afraid of it. So I think there's a bit of, oh, I don't want to go there sometimes.
Yeah, thanks for the talk. Now you're at CDU. I'm just wondering what you're hoping to focus on in your own sort of role and teaching and research and things.
I've actually put in a bid, which is due this Thursday, to because mental health's my other passion, and suicide prevention. So I don't know if I'll get it. It's a $3.75 million bid to establish a national peak body for mental health consumers, and it really resonated with me that EOI, because the whole thing around cultural safety is there, and I think mental health have actually taken the lead in cultural safety, so that's something I'm working on at the moment, and working with people in rural and remote areas. So I'm working on a grant for that as well, where you don't have to use the internet to receive a service. So I've got some ideas on digital technology. That's my other area. But cultural safety is always there, because you're working with people, I think. So. But yeah, let me know any funding that's going around. I'm not proud.
Any other questions before we wrap up? Online?
So yeah, I really liked seeing the progression of awareness to sensitivity, sort of building blocks for cultural safety, and how that's embedded across the 3 years of nursing training, because it is like, it's just, we're all on a long journey. It takes a long time to sort of have an understanding and see that play out in practice. And I find that across that period of time is so wonderful. I was wondering if it's embedded into other health training programs like allied health or medicine, whether it's sort of expanded out across New Zealand more broadly and into other courses as well.
Yes, the standards for registration, it's in all of the allied health now, and how they teach it's really up to them. There's no like standardised practice, but they've embraced it. And occupational therapy and physiotherapy, I've been most impressed. They have a really lovely holistic way. Anyway, I think especially OTs in the room. But yeah, I think certain professions that have that leaning anyway will embrace it. But yeah, standards for registration, you do have to have that. Not so much in education. I don't think the teachers' registration use that concept. So there is a tension between competency and safety, because we have the Health Practitioners Competence Act in New Zealand that has all of the professions under it, and they use the word competency. And so because nursing says safety, there's a bit of a tension in how do you demonstrate competency and safety. So I use the story of my son, who's now 24, and he's got a driver's license, so he's competent to drive. But I don't like driving with him because I feel unsafe. He just speeds a little bit too much, he cuts the corners, and I'm like holding on, white knuckles in the car. So I use that sometimes to help people understand, you know, the difference. So you can have a certificate, say you're competent, but then it embeds it in the experience of the person receiving the care, or in my instance, you know, sitting in the car next to him. And so that's the beauty of it. I think it really has the power embedded with the person receiving the service and the care. Yeah.
Thank you. Do we have one more coming from you, Alan?
Yeah, I was just thinking to follow that up, perhaps, that CDU is obviously focusing on teaching and growing courses to meet the need for the range of health professionals in the NT, where issues of cultural safety would appear absolutely fundamental. Is there an opportunity to engage with, I suppose, there's work towards a new medical curriculum?
That's right.
To hopefully start in the next year or two.
Yes.
So I'm just thinking about the opportunities to shape, if the university is to teach people to really be skilled to work in this environment, it's incredible.
I agree, and the conversation needs to be an and. So it's not only Indigenous experiences, so we don't want to limit cultural safety to that tick the box, that's it. It's an and, so it's intersectionality, you know, disability, it's all those things that in the concept's meant to be about that. So you start with the First Peoples and then you build on that. So I would encourage, those new developments to not just stop and think we've ticked a box, we've consulted, you know, First Peoples. We need to keep doing more. And I think these days, with intersectionality, that's the term I'm using, we need to do better, because if we get it right with First Peoples, I suppose we can use those tenets and try and get it right with other people as well. Yeah. I know Di Stevens quite active in that space here. And I do really good education sessions for cultural safety, and that's for allied health.
Right. Any more questions? All right, great. We can wrap up now. Thank you so much, Dianne. Thank you.